Thank you, Professor.
Thank you.
Thank you very much. That was thank you very much. That was very informative video as well. But we already got some questions in our chat box, and I'm sure there are many doctors who would like to communicate with you during this meeting. So can I read the questions for you, or shall we take some time?
The text is better, I think. Yeah, text and
yeah, they're texting.
Yeah.
Yes. So we do have some questions. Let me just read it for you.
Yeah.
Okay. So here's a question from Mr. Nur Adura Yaqub. Is there a limit to the volume of nodule that can be ablated in per session?
Yeah. For one season is 30 cc. Above 30 cc, always you need a second season. But for the second season, it's better that you do it after minimum 8 or 9 months, because the volume reduction process duration is 6 months, and you must wait the 6 months, and then you can do second session. It depends on the stiffness of the nodule. If the nodule is very soft, sometimes you don't need a second session. That's my answer.
Okay. Thank you. And do you ablate isthmic nodules?
Yes, if you do a good hydrodissection between the strap muscle and thyroid capsule, you can do it. And the advantage of isthmic nodule ablation is most of these nodules have cosmetic problems you can see from outside. And after 6 months, the cosmetic results are very good. This group is very good candidates for thermal ablations.
Okay. Thank you. Another question from the Mr. Nur Adura is that for larger multinaudial goiter, how long is the interval between treatment sessions?
Yeah, I said before, minimum 6 months. But in a clinic, if a patient have multinodular goiter or multinodular goiter plus plongeon goiter or mediastinal involvement, we do thyroid embolization before, and we wait 3 months. After thyroid embolization, the thyroid parenchyma shrinking, but the volumes don't, but nodules don't shrinking. But while the thyroid parenchyma shrinking, it's more smaller and more higher, and then we ablate it in this group of patients. But normally between 2 sessions, we must wait minimum 6 months.
Okay, thank you very much. There's a Dr. Mark Hamlin. Is this safe in an outpatient clinic versus hospital?
It's a hospital where I work.
Okay.
I can't understand the question. Can you say it again, please?
The question is this a safe treatment in an outpatient clinic?
Okay. Yeah. It is very safe. You can do it in an outpatient clinic. It is normally 1 hour procedure. I see in some countries they do it in operation room with general anesthesia, but I don't think it is right, because the motto of this thing is minimal invasive treatment. If you do a good hydrodissection, if you evaluate before the ablation the anatomical structures, and you don't need to do it at the hospital. You can do it in a private practice or in a clinic.
Okay. Thank you. I think here's one doctor, Dr. Daya. He has a different opinion about the multinaudial goiter. He thinks it is a contraindication to ablation. What is your opinion on this one?
Yes, I think you have right too. The goal is how many nodules have the patients. If the patients have in both thyroid lobes 20 or 15 nodules, yes, it's right. Ablation is not effective. Operation is better. But the patient is a young patient, and in one thyroid lobe she have 2, and in the another thyroid lobe she have 3 nodules. In these cases, we can do ablations. It is very important. And I think the main goal of this procedure, what we speak, is to preserve the thyroid gland. It's very important for everything. A young patients come, she have totally 5 nodules. In one sessions, we do the left side example, the 2 nodules in one session, and we call she after 1 month, and we do the other side. And she don't need lifelong thyroid hormones, and she preserve her returns. But if the patient have 10, 15 or 20 nodules, yes, it's right. It is not a good choice for thermal ablation.
Okay, thank you. Thank you for the explanation. And we have another question from Dr. Ahmed Mamoun. Is there any maximal size of the nodule? I think the question is about the maximum size that we can ablate during this treatment.
Yeah. The only criteria is if we can see all the parts of the nodule at the ultrasound, we can ablate it. Another things are with the time. And my biggest nodules were 170 cc, but the time was with microwave 25 minutes.
25 minutes.
Depends on the time. Okay. And the second criteria is we must see all the nodule part on the ultrasound. If we can see, we can ablate it. And here have a second question. Do you use consequent sedation or only local anesthesia? I use every time only local anesthesia. The patients don't need sedation because it is a very simple procedure. But for this, I talk with the patients too much to make the stress more lower. Okay.
Right. Yeah. We as we know, many doctors out there who are using microablation to treat thyroid ablation, they are also using local anesthesia to have a better response from the patient during the operation.
Yeah.
Okay. Next question is from Mr. Jacob. Is water cooling needed in the hydrodissection? I think
I don't understand it.
I think it's about if I'm not mistaken, this sorry.
Yeah. In hydrodissection, we use a normal needle. We go inside and give the fluid. We don't need a water cooling needle. It's normal needle injector what we use for.
Is the hydrodissection solution needs to be cooled down for this one? Like it's
okay. Yeah. Okay. Normally, I use cooled fluids. They're always in the defibrillator. It's better, but not so cool. But cold is better for prevent thermal injury. Very good questions. Thank you for these questions. It is a very important trick. Please use in hydrodissection cold fluids. It is better for avoid thermal injuries. Yes, I forgot this to explain. Thank you for these questions.
Thank you, Professor. And questions just keep coming. So another expression by Dr. Daya: ethanol ablation is contraindicated during pregnancy. Is that the case for other ablation techniques?
Yeah, it's right, but microwave is not contraindicated, but RFA is contraindicated in pregnancy because we use ground pads in RFA and the patients have a ionic current. Therefore, we cannot use RFA, but in microwave, we can use. I have 3 or 4 cases that I do if the patients have, normally it's better that we wait that the pregnancy finishes, but if the patient if she have very big problems, cosmetic or symptomatic, I have 3 and 4 cases, we can use microwave ablation in pregnancy. We have no contraindications.
Thank you, thank you. And another question from Dr. El-Sadiq Ahmed. What's the main investigation and the gold standard to detect the goiter?
Ultrasound. Ultrasound is very non-invasive and very easy, and the cost is very low. Ultrasound is the best choice.
We're moving on to the next question. So Dr. Ahmad Mamoun asked, hydrodissection needle you use is 20 ml or a spinal needle?
Normally I use only 20 ml, but in some cases, except in parathyroid adenoma, if I must go to a deeper site, then I use spinal needles. But normally I use only 20 ml is enough.
Okay, got it. Another question by Dr. Kwon-Lun Lok. Can you ablate left and right nodules in the same setting?
Yeah, we can do it, but I think it is risky. Why? If we have both, it is very rare, but if we have both thermal injuries at the vocal cords, it is life-treated complications. Therefore, it is better that we do one side in one session. That is my decision, because I will make this procedure very safe. I know that my friends do it in one sessions, but it is too risky. It is a new technique. We must not have complications. It is better that we do it in 2 sessions.
Thank you, thank you. And moving on to the next question from Dr. C. Kim Sim. Do you confirm the post-ablation zone with contrast-enhanced ultrasound?
It's very good questions. Thank you. In my country, we have not ultrasound contrast. Sorry. Therefore, I can't confirm this, but I read many research papers. Most of them is in Italy and in Korea. They use it. I think it's very important today to do this, but in my country, we have not this country. It is a gold standard to use contrast ancient ultrasound.
Okay, so Professor, in case, okay, so you're not using contrast enhanced ultrasound in your own practice, so how do you evaluate the immediate after ablation results? Color Doppler?
Yes, the first is the ablated zones are more hyperechoic, and the non-ablated zones are hyperechoic. The first is the grease color. The second is color Doppler, and that's enough mostly.
Okay, thank you. Another question from Dr. Chum. Can you explain more about the vascular ablation to prevent recurrency? Any risk of bleeding? I think that's nodules with vascularization.
Yeah. In some cases, in venous, if in some cases in nodules that have a very strong venous supply, do you know in fine needle aspiration biopsy we have some complications. We go with a very small needle and the nodule bleeding, and we press. If we see this in ablation, we continue the ablation to make coagulation, and we have no problem. But in experience, venous, if the nodule have the hemorrhagic nodule, the patient have a hemorrhagic nodule, this nodule have a big potential to bleed at the procedure. In this group, it's better to use away because frequency ablation, while they the tissue impedance and heat sink effect, we cannot to bleeding. In microwave, no problem. You can only, the trick is if bleeding, do moving shot, stay at the artery, make a coagulation, it's enough.
Okay, okay. Microwave does have the effect of coagulation.
Yeah.
Okay. We have another question from Suthida. It's a little difficult to pronounce the name. I hope you don't mind. The question is, do you have any experience or heard about transoral endoscopic thyroidectomy vestibular approach, which is TOE, TVA? As I know, this technique no scar after surgery. So what is the benefit between this technique and microwave ablation?
Yeah, in hospital, we have very endocrine surgery team. They do in 1 month, 20 cases with high level. And I attend some operations to see the technique. It's very fine, but technique time of operation is actually minimum 2 or 3 hours. And yeah, she has scar, but no thyroid for the procedure. The problem is this. After the she has scar, but they have no thyroid. Remove the goal of this process to have the thyroid. After technique, the patient not scar, she have not done. That's the
Okay, thank you. I think some are interested if they want to know if the N can be. I think this question I can answer. For ablation antenna are not reusable. We would not recommend it. So we hope that you go by the manufacturer's advice. So thank you very much. And we are moving to the next question. If thermoablation of one side, we don't do ablation on the other side. It's the question was asked.
Yeah.
So that's recommended.
Yeah.
Okay. And the following question is that, do ablation leave neck adhesions like neck surgery?
Yeah. If we don't use hydrodissection, of course, we have adhesions. But if we use local anesthesia between the stress muscle and thyroid capsule, we have no adhesions around the thyroid glands. Or in one webinar, general surgery say to me that after thyroid ablation, they cannot do. I ask him, and she don't answer. If hydrosection, never adhere, and say every time patients ablation, the never time operation in the future, it is not contraindicated. We have no adhesion after.
Okay, thank you very much. Okay, just wanted a little update. So Dr. Carlos from Brazil, who has microwave in his own center as well, wanted to have some discussions with about the ablation. But he had so sent his words. Yes. So another question I think would be the last question to have today. Are there alternative to volume for dissection?
Important the intensity or the molecule. I in some cases 20% dextrose, but the problem is patient's hemodynamic are changed. It is too intense and too much sugar. But Voluben is more safe. Normally, I will give another explain. Normally, I learned this technique from the general surgeon because the general surgery use volume in submucosal polypectomies. The same mentality, and it is very safe. Therefore, you can use it.
Okay. I hope that cleared a lot of, yeah, that helped some doctors, I'm sure. And we have another question. Is it possible to treat residual thyroid tissue post-thyroidectomy in papillary thyroid cancer?
I don't prefer this. It is better to treat papillary carcinoma or papillary or nodules. And the problem in this case group is the recurrent laryngeal nerve course changed very much, and the thermal injury risk is very high after surgery. I read some research papers, and there are some experimental studies that they ablated residual thyroid tissue in swines, in pigs, but we have no human experience about this.
Okay, thank you very much, Professor. I saw that Dr. Niyaz Malayev from Kazakhstan also joined us today, and I know that he does radiofrequency ablation. So I don't know if he's ready to come up online just to have a little communication with us. Let me invite him to turn on his microphone. Dr. Niyaz, are you here? Hello, I think he's here. Not sure if he can hear me, but okay. Anyways, so if we're to continue, we would have many more other questions from the audience. I'm sure doctors are interested in the thyroid ablation, but they have many questions before you know, taking the step to do their own cases. So in that case, I think our education will continue in this way. Someone raising their hands, should we let them finish, Professor?
Yeah, thank
Okay.
you. Thank you for everything. Thank you for your opportunity that I can share my experience. And I tell very much things about this procedure, but if you have some experience, if you make your steps very careful, it is a very easy procedure. I think this is the future, and we must with the future. Thank you for everything.
Thank you, Professor. I'm sure it will just take a little longer time to spread the awareness of this technology, and thanks to you, we are able to have this kind of activities to do that, and I'm sure in future we'll have more cooperations on this sense. And thank you for everything. Thank you very much. If we have any questions from our audience in future, we will definitely come back to you.
Thank you.
Thank you. So thank you everyone for participating. If you have any questions, you know where to find us. So thank you. Have a good afternoon for you all. Thank you.